Hello, and welcome to an overview of preeclampsia. Preeclampsia is a serious clinical condition that affects 5 to 8% of all pregnancies. Preeclampsia particularly occurs in nulliparous women and mothers with multifetal gestations, previous preeclampsia, chronic hypertension, pregestational diabetes, vascular and connective tissue disorders, nephropathy, and obesity. Preeclampsia is a systemic disease characterized by vasoconstriction resulting in hypertension, edema, and intravascular depletion. There are many theories about the primary cause of preeclampsia, but the most popular one suggests that a higher than normal trophoblastic invasion might be the culprit. One theory that is gaining favor involves an increased circulating concentration of the S-FLT protein, a soluble form of the VEGF receptor. S-FLT is a VEGF antagonist and may be responsible for the vascular damage and resulting vasospasm and vasoconstriction of preeclampsia. Hemolysis and vascular damage cause capillary leakage as well as vasospasm, which means that fluid therapy to correct the hypovolemia may actually cause an elevated pulmonary capillary wedge pressure as well as pulmonary edema. Mild preeclampsia includes a systolic blood pressure of greater than 140 or a diastolic blood pressure of greater than 90. In severe preeclampsia, these values are 160 and 110 respectively. Patients also classically present with proteinuria greater than 5 grams per day. If preeclampsia progresses to HELLP syndrome, then clinicians may also observe elevated liver enzymes as well as thrombocytopenia. Patients may also report severe headache and visual changes due to increased intracranial pressure. Subcapsular liver hemorrhage may also be associated and may present as right upper quadrant pain. Disseminated intravascular coagulation may also be a manifestation. Finally, uteroplacental insufficiency and general hypovolemia may lead to intrauterine growth retardation and preterm labor. The most feared complication of preeclampsia is progression to frank eclampsia and maternal seizure. It is important to administer weekly non-stress test biophysical profiles and twice-weekly evaluations of oligohydramnios and fetal growth restriction. Maternal platelets, liver enzymes, renal function, and proteinuria must also be closely followed. Maternal hypertension should be managed with hydralazine in 5 to 10 mg doses every 15 to 20 minutes, as well as labetalol. Severe preeclampsia should be treated with magnesium sulfate for the prevention and treatment of seizures. Patients on magnesium therapy should be monitored carefully as toxicity can occur, in which case calcium chloride should be administered for cardiac protection. Prolonged fetal heart decelerations can occur if there is a progression to eclamptic seizure, so the best way to protect the fetus is to stabilize the mother. If anesthesia is required during delivery, then a regional anesthesia should be used, as it has been demonstrated to be safe and effective. Finally, calcium and aspirin have not been shown to be effective in the prevention of preeclampsia. Thank you for joining me, and I hope you've enjoyed an overview of preeclampsia.